think it's a good time to get started. Hello, everyone. Welcome to our discussion on alternatives to opioids. We're talking about pain therapy treatment options. We have a great panel for you tonight. Thanks to the doctors from Garden State Medical Center for joining us, Dr. Mon, Dr. Sarah Choksi, and Dr. Samir Jani. Thanks for volunteering your time at the end of the day to hop on and give more options to your patients and educate them on options for pain therapies. Tonight, we're going to be together for about 60 minutes, advanced therapies, who's going to share their experience and how it's impacted their life. So I encourage everybody to stay on until the end of the call. We're also going to be collecting questions throughout the call, and we're going to be addressing them the best we can. So periodically, we're going to answer questions, and then at the end, we're going to address as many as we can. So once again, I encourage everybody, Q&A feature where you can type in your questions. This is through Zoom. So through the Zoom platform at the top of your screen, or it could be at the bottom, you see the Q&A section. So you can type in your question there. The panelists will see it. We're recording these questions, and the doctors will address them at the end. Or you can send me a private text message at 609-203-5214. And I'll also be collecting all of your questions. Presenting tonight, many of you waiting surgery for their patients, offering these minimally invasive techniques as an alternative to opioids. So without further ado, I'm going to pass it over to Dr. Sarah Choksi.
Thank you, Austin. So briefly, I just wanted to introduce those of you who are not familiar with our practice. Dr. Mon started Garden State Medical Center back in 2004 as a way to really offer the people of Ocean County a more state-of-the-art treatment therapy for people who are suffering from both acute and chronic pain. Our practice includes 4 double board certified anesthesiologists and interventional pain specialists. And we've been, like I said, in Ocean County since 2004, continuously providing, the people here with a lot of different options for pain management other than just medication management. Take the next slide, Austin. So today, Dr. Jani and I are briefly going to cover, the topic of chronic pain management options, and we're going to kind of try to delve into what all the different therapies are and what therapies might be more specific for your chronic pain issues. We're going to kind of broadly cover these topics, and then that way you'll be able to sort of take some of these things that you learned today and discuss it with your pain physician at your next appointment. Just as a reminder, we wanted to let everyone know that, as a response to the current pandemic, we are taking extra precautions in all of our offices. We've had certain changes in our protocols. We make sure that we check temperatures upon entering. We have limited our patients, to their specific time slot only. We've also made sure that all of our staff is tested regularly, and fever checks are done every day in our offices. So we have taken all of these additional measures to make sure that all of our patients are protected during this time. Next slide. So briefly, before we delve into the current therapies that we're offering our patients, I kind of just wanted to briefly go over the 2 main kinds of pains that people experience. So there's the mechanical, or what we call nociceptive pain, versus the neuropathic pain. The nociceptive or mechanical pain is more commonly associated with an acute injury, something that happens within a couple of weeks, usually typically lasting less than 6 weeks time. And it usually has to do with any kind of acute injury or inflammation that's occurred. For example, if you've stubbed your toe or if you've broken a bone, those would be signs of a nociceptive pain. Whereas neuropathic pain, which is commonly what we see most of our patients in the clinic for, is related to nerve injuries. It can be anywhere along the nervous system where the nerve has been injured, but these symptoms are commonly described as burning or aching, shooting, stabbing types of pain that has usually gone on for a period of 3 months or more. So if you are suffering from these kinds of symptoms like weakness or numbness, pins and needles, any of those kinds of symptoms, that would sort of fall under the neuropathic pain, which we have a lot of different therapies out there these days to treat. I'll take the next slide, Austin. If your chronic pain is preventing you from doing basic household chores, from vacuuming to, simply picking things up off the floor, or an inability to even go to work. I know a lot of my patients, find that their grandchildren want to play on the ground, they want to run around, and, you sometimes can't do those things. And it's agonizing to say no to a young child. And it's very difficult on our patients. And so, doing outdoor things like walking and hiking or exercising, whether it's Pilates or yoga Pilates, gardening, in the summer and spring, or doing arts and crafts in the winter time. A lot of our patients suffer from, not having the life that they once had. And I think that the therapies that you'll hear in the next segments of this talk will really give you options that you may have in order to treat your pain, to once again enjoy doing these things and really give yourself the quality of life that you're looking for. You probably tried a lot of therapies. Most of our patients start off at their primary care doctors, having already given them, a steroid pack, or perhaps prescribed them some common over-the-counter medications in higher doses like naproxen or Mobic, or, sometimes even Tylenol number 2s and 3s. And they've tried physical therapy, and sometimes physical therapies even made their pain worse. Sometimes they've been to a chiropractor, tried acupressure or acupuncture. They've applied TENS units. Opioids are, ineffective, or they're noticing that they're needing more of the opioids in order to treat the pain that they once were able to manage easily. There's also more advanced therapies like drug pumps. You may have gone to a surgeon for an evaluation, but aren't quite ready to bite the bullet, or maybe you've already had surgery and it hasn't worked out for you. Our office offers multiple different modalities, some of which include a nerve block, in order to really treat and nip the pain in the bud. Take the next one. So Dr. Jani and I are going to focus on 3 of the main therapies that are out there right now that our office specializes in. The first is radiofrequency ablation. The second will be an indirect decompression known as Vertiflex. And the third one is spinal cord stimulation. The radiofrequency ablation can be used to treat not only just back pain, but it can also be geared towards knee pain, hip pain, as well as neck pain. I'll kind of talk a little bit more about that option. I'll take the next slide. So radiofrequency ablation, in brief, is a minimally invasive outpatient procedure. What that means is that you come into our office, we do the procedure under light sedation, typically in a matter of 5 to 10 minutes, depending on the area that we're looking to ablate. And you go into our recovery area until you're awake, and then go home that same day, hopefully in a lot less pain. This option is great for patients who've failed medication therapy. You've tried steroids, you've tried pain medications, and they just aren't giving you the relief that you seek. The radiofrequency ablation is basically a targeted therapy that targets the sensory nerves, and it basically applies heat over that area for a period of about 90 seconds in order to burn that nerve off. Nerves do unfortunately regenerate over a period of time, but the standard is that we believe this is an effective therapy for anywhere from 6 months to 2 years, sometimes a lot longer even than that. I'll take the next slide, Austin. I know Dr. Jani is going to go ahead and talk a little bit more detail about the Vertiflex procedure, but I'm happy to entertain any questions about the radiofrequency procedure that we may have at this point.
At this time, I haven't seen any questions come through.
Okay, great.
Dr. Shotzi.
So I guess I'll go ahead and start discussing the Vertiflex procedure. I just wanted to say thank you to all the participants for taking some time out to try and learn a little bit more about something that may offer you some benefit. So regarding the Vertiflex procedure, it's a minimally invasive procedure where we go ahead and insert spacers in between the spine. Now, as you can see in the picture, there's parts of the bone that are called the spinous process. And what we do is gently place this device in between them. And it's almost like a car jack if you're about to go change a tire. It sort of gently pushes apart the bones and can take pressure off the nerves, both in the middle as well as from where they're leaving out of the spine. Can you go to the next slide, Austin?
Mm-hmm.
Now, this procedure is indicated specifically for something called central spinal stenosis. So you can have tightness around the nerves that come in the middle of the spine, and then there's something called foraminal stenosis, where you can have tightness of the nerves as they are exiting the spine. Typically, patients who suffer from spinal stenosis, if you pay attention towards the left side, will have a lot of symptoms as they're especially standing and walking. And so typically they feel fairly good while sitting or at rest. As they start to stand for a longer period of time, or they go and walk for a longer period of time, they start to gradually increase the pain that can be radiating kind of down in between their legs. It can also manifest as just back pain. And it gets to the point where patients often have to sit before they recover and they're able to keep walking again. Part of the reason why this occurs is because there is so much tightness around the nerves. When there's tightness around the nerves don't get the blood flow they need to be able to keep firing in order to control the legs, which allow you to stand and walk. And that's why if you look towards the right of the screen, you'll see that most patients do get some benefit by leaning forward or sitting to relieve these symptoms. And you can see the picture of the woman pushing on a shopping cart. I mean, that is a classic sign of spinal stenosis. It's actually known as shopping cart sign. So in general, you would have a lot of pain in the back or the legs if you're trying to stand upright without some support in front of you. But once you have that support in front of you and you're able to lean over a little bit, a lot of the symptoms improve. And that's because by leaning forward, you're actually allowing for better blood flow locally within the spine, allowing those nerves to keep working and firing. Now, again, we often don't start with this procedure right away when you're dealing with some of these issues, right? So if you do have spinal stenosis and you do have pinched nerves, going back to what Dr. Chassi said, typically we would start with some physical therapy, some minor injections, maybe some medications. But if you've progressed beyond that and we've tried some of those things and you're still having these issues, then this may be a reasonable option. Next slide, Austin. So again, this is a pretty good description and a picture of what spinal stenosis looks like. So if you are able to focus on the picture of the healthy nerve, you can see that the yellow nerves aren't being pinched, and that's because they're not being squeezed. Often it's a combination of factors that cause the pinching. So normally it's not just one problem. It's a common trifecta that causes the pinching. So what are those? Arthritis in the back, herniated or bulging discs, and then something that occurs naturally as many of us age is something called hypertrophy of the ligamentum flavum. So what that is, we all have a ligament in our back, which helps to provide support to the back. Over time, with repeated bending and use, that ligament can grow in size. And so when you take into effect that these three structures all start to take up more room than they should, that's what results in the pinching of the nerves. And that pinching, like I said, can happen both in the middle of the spinal column or off to the side as the nerves are leaving. And that is classic for pinched nerve pain. And I think many of the patients have experienced that typical sciatic pain kind of shooting down the leg. Next slide. So the Vertiflex procedure is a very unique procedure that does have pretty significant data behind it. I think if you look at this slide, I'm going to jump to the sort of last point, which is this has been around for several years now and has been quite effectively studied, having read the studies myself. In general, the process is once you're determined to be a candidate, it's an outpatient procedure, takes approximately 30 to 45 minutes, depending on if we need to treat 1 or 2 levels. You would typically get a single incision if it's just 1 level, or 2 incisions if it's a dual level. The incisions are less than 1 inch. The procedure is an outpatient procedure. Everyone goes home the same day. And I think one of the highlights of this procedure is it doesn't burn bridges. It still leaves many other options available to patients because we're not fundamentally changing the anatomy of your spine. We're not taking out bones, we're not taking pieces of your disc out, which is what most other surgeries do achieve. When you do those sort of things, that can lead to other complications down the road. By gently just pushing the bones apart, this does leave options on the table if for some reason this doesn't work, or the problem continues to get worse and worse, which can occur with most of these degenerative issues within the spine.
Dr. Johnny, we did have a few questions come through in the chat function. And I apologize to everybody. It sounds like there's a little bit of delay on my end. It might be the service connection. But I'm going to read off this question because it's related to both radiofrequency ablation and Vertiflex. The question is, do you do the radiofrequency ablation first or the Vertiflex procedure?
Well, so, and Sarah can obviously chime in, but it all depends on what we're diagnosing and what we're treating. So typically radiofrequency ablations are used for spinal arthritis. Now, as I said, spinal arthritis can be a contributing factor to the spinal stenosis. However, if your pain complaints are more consistent with the arthritis issues, then we would go down that pathway. If you have more of the stenosis issues, then we would possibly go down the Vertiflex pathway. So there's no sort of correct answer. It's very much patient dependent. It depends on what you're complaining about and what symptoms you have.
Yeah, I think that's, it's a great question. The ablation is typically intended for patients who have localized back pain, like Dr. Johnny was saying. If you have pain going down the leg, that suggests, like you were saying, that you have a pinched nerve or coming from probably spinal stenosis at some level. The radiofrequency ablation, like Dr. Johnny had mentioned, you can have a Vertiflex procedure and still get a radiofrequency down the road as well if you have just low back pain. If the pain is coming from the joints themselves, then the radiofrequency ablation is probably the best option. And like I said, again, the pain is usually, when it's coming from the joints, it's typically just localized to the back. And that's where the RFA or the radiofrequency ablation is going to be most effective, when the pain is just like above the belt line and just localized to the back. And typically it happens with like bending first thing in the morning. It's your typical arthritis pains. It's the mornings are typically very stiff feelings. Any movement of the spine causes pain in the low back. You constantly feel yourself like gripping your back, to try to smooth out or soothe out the pain. But that's what the ablation therapy is typically for. But just because you have a Vertiflex doesn't mean you can't get the ablation down the road. And vice versa, if you get the ablation, that doesn't mean that down the road, if you have spinal stenosis, that you can't get the Vertiflex. Oftentimes our patients do need more than one therapy because there is, as our spine ages and as we've used it, you not only have arthritis and you not only develop arthritis, you do also develop spinal stenosis. And that's just from overuse of our backs and our spines and our bodies.
I just wanted to add in one other point, which is, and I think you brought it up towards the end, is that most individuals don't have just one problem. And that's because all of these structures are essentially right next to each other. And so if you have an issue with one, the inflammation from that issue can sort of spill over onto some of these other structures. And so there's a fair number of patients who, let's say, really their main problem is the arthritis in their back. And when it really gets going, that's when they start to feel the shooting pain down their leg. And what's essentially happening is the arthritis in the spine gets so bad, the inflammation spilling onto the nerve, which sits right next to it. And that's how you start to get the pain down the legs. So again, the best way that we sort of try and figure this out is really sort of listening to what you guys tell us, taking a good history, and putting it together with a physical exam to come up with what we think is your biggest issues, and then take it from there.
Thanks for the in-depth answer. There's another question that came through, and this might help if I get fancy with the drawing on this diagram. But Dr. Joni, the question was, how does the Vertiflex procedure make pain more manageable? So I highlighted in this diagram what it's doing to the nerve here.
Yeah, so I think, a really good description for the Vertiflex is it's the equivalent to a stent in the spine. I think many patients are familiar with stents that they use in cardiology or vascular surgery where they try and open up blood vessels so you can get better blood flow, right? This is a fairly similar concept. What we're trying to do is basically gently push those bones apart just enough to not only unpinch the nerves, but then also improve the blood flow that's in that localized area of your spine. And by doing that, we should see some improvement in a lot of the symptoms going down from the back and into the legs. And I think what Austin's highlighting there is in that first picture on top, the nerve is being pinched. And if you compare it to the picture down below, by pushing in the Vertiflex, you're able to push those bones apart and then unpinch the nerve.
There we go. Got it right that time. All right, there's a lot of questions coming through. We're going to save most of them for the end, just in the interest of time. So we'll continue on to the next slide.
So again, as I said, having read the studies, the team at Vertiflex and Boston Scientific have done a very good job of completing some rigorous studies to really sort of put this to the test. And the data is pretty clear. And I will say that I do think that this mimics our practice's experience. Now, don't get me wrong, nothing in life or medicine is always guaranteed. And we always use our diagnostic tools to pinpoint and predict who's going to be a good candidate for what type of procedure. But I will say, and I think the highlight would be the first box. The majority of patients who have had this procedure are satisfied with the outcomes. Now, it's, again, not 100%, but a big chunk of patients do feel like this was worth going through. And that's partially because, again, it is not as invasive as many other spine interventions can be, especially when looking at it from a surgical aspect. In addition to that, the majority of patients do see functional improvement. And so our goal is not only to minimize pain or reduce pain, our goal is also to see you be able to stand longer, see you be able to walk longer. And I do feel that the majority of patients that I've done this for have had that benefit. So another therapy that we commonly use for a variety of conditions is something called spinal cord stimulation. And in general, the best way to sort of think about this, and again, using another analogy from cardiology, is that this really sort of is a pacemaker for the spine. A lot of the basic science and a lot of the fundamentals of these devices was born out of pacemaker technology. So there's many times that in medicine, doctors use electricity to help control various body parts. So for instance, in patients with certain movement disorders or patients who have had some brain trauma, you can use something called a deep brain stimulator to target the brain and get the body to do what you want it to do. Cardiologists, like I said, use pacemakers to apply electrical signals to get the heart to do what we want it to do. And over the last really 15, 20 years, there's been a lot of research and development poured into trying to control pain signals using electrical signals. And so that's really where spinal cord stimulation comes in. So again, spinal cord stimulation is meant more to treat what we call neuropathic pain, which is nerve-related pain. Often patients who have nerve-related pain may suffer from neuropathy, which can be from diabetes, can be due to being exposed to various chemotherapy agents. Other individuals have nerve pain because they've had trauma, car accidents, motorcycle accidents, injuries to various affected limbs. Another big indication for why we use spinal cord stimulators are for individuals who've already had back surgery and still dealing with a lot of pain issues. Often in that population, a lot of our injections don't significantly help, or if they help, they're relatively short term. And part of that is because when you've had back surgery, it automatically changes your anatomy. And a lot of the time, that also means that you've developed some scar tissue in there. And that combination can make it very difficult for the medications from our injection to sort of spread around. And the beauty of spinal cord stimulation is you can kind of go above the area of damage, targeting the spinal cord itself. Now, again, this is not a first-line treatment. This is not the first thing we sort of jump to when a patient walks in, having never seen a pain doctor before. This is reserved for the more difficult patients to treat. Like I said, individuals who have already had back surgery and have already tried the injections. I think in general, it's good to recognize that even beyond some of the indications that I've talked about, I've had success using spinal cord stimulation to treat a variety of pain issues. It's a very powerful tool in the arsenal of a pain doctor. Now, it does it does involve a implanted device, and that is a individual discussion to have sort of with your doctor. So again, as it says here, it's been around for many, many years. The best way to sort of understand how this works is, I think we've all sort of bumped our elbow or bumped our knee and it starts to hurt. And so what do we automatically do? We start to rub it. And the way that works is you injure yourself. Let's say you hit your elbow. It starts to hurt. Your elbow is sending pain signals and your spinal cord is transmitting that up to your brain. And that's how you feel those signals. When you start to rub your elbow or your knee, whatever you hit, what you're doing is you're activating something called mechanoreceptors within your skin. And those are specialized nerve transmitters, which then send other signals into the spinal cord. And when both of these signals reach the spinal cord, it has to choose what to listen to. It can't pay attention to everything. And so by rubbing, you're trying to overstimulate the pain signals and make the pain signals become the weaker one. And so your body starts to listen to the one that's more powerful. This is the basic premise of how spinal cord stimulators work. Now, it does get a little bit more nuanced, and I don't think it's necessarily something that we need to go into, but this is the fundamental way we believe that the spinal cord stimulators work. By overpowering these pain signals, stopping them within the spine before they get to the brain, we're able to control the pain or diminish the pain significantly. Again, this is a FDA-approved therapy, and I had mentioned really in about the last 20 years, there's been a lot of competition, which is good for patients because it forces companies to adapt and make their products better for use for patients. And so the level of data that is being poured into this therapy from the various manufacturers allows us to really pinpoint which type of treatment option is best for which patient. Many patients turn to treatments like this because they are unable to tolerate oral medications, or they have noticed that they don't work as well. Now, the benefit of this system is that it is covered for the correct indications. So it's important to know that these treatment options are covered by most major insurances as well as Medicare.
Dr. Johnny, I think this is a good time to transition over to our patient speaker who's implanted with this therapy. It's always helpful to hear it from somebody who's living with this device and hearing their journey and how it's impacted them. So I'm going to introduce Justin. He has been implanted for over a decade with this technology. He's a veteran, and his story is pretty touching on how it's impacted his life. Hey, Justin, how are you?
I'm well, sir. How are you?
Not too bad. Thank you for joining us tonight.
Absolutely. Thank you very much for the time. I'm sorry. I was stepping out. My daughter just got home from school. I am a chronic pain patient. I have been for a long time. I got this way after a 15-year career as a special operations interrogator in the Army, and just multiple injuries over the course of my career. The only difference between now and when I was serving and recovering is the way I'm kind of dealing with the pain. For me, it all started with my initial injury, was a spine injury on September 11th, 2001. I was a first responder at the Pentagon. And when I was trying to reach a woman that was trapped underneath 3 floors of debris, the building collapsed on me. So I fractured my spine at a couple levels and damaged some discs. At the time I was 21. And following that injury, I had my first of 6 total spine surgeries throughout my career. And after recovering, I deployed, and I kind of set the tone for the rest of my career, which was injury, surgery, recovery, deploy, injury, and just kind of rinse, wash, and repeat. I made it throughout 8 deployments and almost 14 years before my body just gave out. And my after my last deployment, when I was medevac to back, the doctors explained I had some pretty massive spinal trauma and some really severe, if not irreparable, nerve damage. So the fix for that was in 2008 was an anterior posterior interbody fusion at 6 levels. I'm a big dumb Army guy. As I understand it, that's just basically a way of going in from the front to the back and building a titanium cage with a bunch of rods, pins, and screws, holding everything together. It was pretty intense surgery and 3 months recovery, mostly at the hospital. And when I went home, I was really struggling because I was in more pain at home 3 months post-op than I was before I even went on the table. For me, it was the type of pain that really, the easiest way for me to describe it is it dominated, dictated, ran, was in control of every single second, minute, thought, plan, aspect of my life. From long before the time I tried to get up and until long past trying to go to sleep every day. So although I was structurally sound or fixed, we needed to address the pain issue because the surgery didn't fix the pain. So at the time, the fix for the fix, if you will, was long-term medicine management. In my case, that was essentially like throwing gas on the fire. That ended up looking like a 2-year opioid dependency. Daily 240 milligrams of Oxycontin ER, 60 milligrams of Percocet, and 40 milligrams of Valium. So I went from the pain controlling every second, minute, thought, plan aspect of my day to having the pain medication also do the same thing. So it was my quality of life was very poor. My functionality was minimal. I spent 2006, 2007 in a wheelchair, basically living in our guest room, and being a 6'8", 250-pound body occupying space. My brain was in this weird fog. I wasn't getting a lot of pain relief. I was just in pain, but kind of out of my head. So I was able to get a referral to interventional pain management specialist at Fort Bragg, North Carolina. And that was when I learned about spinal cord stimulation. In my case, it was presented more of a last resort kind of option, because we had really run through, over 6, 7 surgeries, injections, ablations, you name it, we tried it. This was something that the doc thought I was a good candidate for, and it was really one of the only things I hadn't tried, which is ironic because you can try it, which is what I decided to do. Every other procedure I had, like that last surgery, a 6-level fusion, once you decide to go forward with that, as I'm sure everybody knows, you're committed. I own that hardware. It's like Home Depot's scrapyard in my back. So whether it works or not, and in my case, it did fix me physiologically, anatomically. Yes, it fixed me, but I was in more pain. And the stimulator and during that referral appointment was so much different because it was presented as something I could try. And then depending on my feedback given to my doc, my team of doctors, and the clinical specialist from Boston, we would then determine if I move forward with the implant. And in my case, I woke up 50 minutes after the trial procedure, the outpatient trial procedure, and 50 minutes there in recovery, we turned on the stimulator for the first time, and it was the first time I felt actual real effective pain relief in easily over 5 years. To me, it felt then, and it feels now, similar to champagne bubbles tingling up in my lower back and in the upper part of my legs. Prior to the stimulator, what I would usually feel in those areas is really like a piercing, burning, stabbing fire poker in my lower back, and then I would feel ridiculous pain in the front of my legs, like lightning bolts shooting on the front of my legs. So there in recovery, all of a sudden, I was feeling that champagne bubble tingling inside of my body that was covering up a good portion of the pain. And it really only got better from there. My trial was 3 days. Shortly after that, I went to implant, and my first implant was in 2009, and we're here today, 2020. I forget what day it is. I think like everybody else, September 23rd, 2020. I just passed 8 years, 7 months clean. Nothing stronger than Advil for breakthrough pain. I'm active adult. My pain, if you have to score it on the 1 to 10 or the frowny face to happy face chart, before implant, easily I was at a 20. If 10's the worst, you could put me at a 20 or 30, no problem. Now I struggle to remember a day that I was above a 2. Rarely do I get above a 2. Most days I'm at a 2 or below. And that's not just dependent on the day, it's also the activities I'm able to do. A lot of things that I wanted to do but couldn't before my implant, like some of it sounds kind of dumb, but like helping my wife unload the groceries, make dinner, walk the dog. All those things I can do now, of course, and the pain's really not, it's not there, it's not a big deal. More importantly for me, my daughter's now 13. She turned 13 this August, and I'm her soccer coach. If you had told me in 2008 that I was going to be my daughter's soccer coach, I would have told you were crazy. First of all, I don't know anything about soccer. It's still today, I just basically yell whatever I hear the other guy on the other side of the field yelling. But to be able to stand out there on the field for a doubleheader match on a Saturday, it sounded insane to me. Now I'm out there. I'm her coach, quote unquote, I guess you'd say. But I'm present. I'm in the moment. I'm engaged, and the pain's a footnote to soccer. It's not a header. It's not in front of my face. It's not something preventing me from doing it. It's not, the pain doesn't fill me with dread about an upcoming soccer game. Nor does going to sleep or making dinner or mowing the lawn. I have a bunch of different programs that are specifically tailored to me that address different pain patterns that present with different activities. And then some baseline pattern pain programs that I run just on a daily basis. The point being, I would be remiss if I didn't say that the stimulator and the therapy it provided, really, it saved my life. It's the reason I'm here today. And it provided a really solid foundation to add on all these other adjunct therapies like massage therapy, acupuncture, exercise, all these other things on top of that base layer of spinal cord stimulation. And it saved my life. I get to be the dad I wanted to be, the dad and the husband that I wanted and failed to be for a long time. The pain stays in the background.
Justin, thank you so much. Such an inspiring story. We appreciate you coming on and sharing that. I think what's really unique is you've been living with the stimulator for 11 years now. Dr. Johnny didn't get to go into too much depth about it, but I think it's really unique that you get to try this therapy out. It's a temporary placement of the stimulator leads. It's usually, in Justin's case, it was 3 days, but it can be as long as 7 days. But I'm gonna let Dr. Johnny go into a little bit more detail. But before I pass it off, we're gonna be launching a poll. This is the third therapy we're talking about tonight. So we just want to keep track of the interest level and what therapies you're finding the most helpful. So you might see the poll pop up on your screen. And I'm going to pass it off to Dr. Johnny.
Sure. So thank you very much, Justin, for that story and sharing your experience.
Yes, sir.
It's very helpful to hear it from another patient because, you know, at the end of the day, we're doctors and we may not necessarily have been in your shoes. So I think Justin did bring up sort of a key highlight, which is unique to spinal cord stimulation. It is one of the few things I can think of in medicine that you get to try before you're sort of fully committed. And the trial is meant to be temporary. It's meant to be your opportunity to test drive the system in your real world life and real world experience. So I know for us, for the most part, our trials typically lasts about 5 to 7 days. It's a outpatient procedure, typically takes 15 to 30 minutes to put the wires in on a temporary basis. We then tape everything to your back. The biggest headache for most patients is you cannot shower during the trial, and that's just a safety issue from electrical standpoint as well as an infection standpoint. But then we really do send you home, and I encourage my patients to try and figure out some metrics to use as a way to see if this is helping or not. And so I always tell patients, look, if you know it's hard for you to do the dishes, well, then we're going to have you try and do your dishes and see if you can do that. You know, it's really difficult for me to be able to walk to my, girlfriend's house down the street. Okay, well, let's see if you're able to do that during the trial. And so it's, again, a combination of not only pain relief, but we are also looking for functional improvement. We want you to be doing more and doing it better. And so if the trial is successful, I try and encourage patients, right? We want home runs. You know, if it's a iffy trial, if you say it sort of helped, well, then it didn't really help and we probably wouldn't move forward. We want patients to really feel that this made a big difference. So that way we're selecting the best patients to kind of move forward with the implant. And again, once we take the leads out in the office, unfortunately, some of the pain may come back. However, we normally are able to get the patients in fairly quickly to be able to do their implants because most of the times the patients don't want me to take the leads out. They want me to go straight to the implant. Just leave this in until next week when you can do the implant. And so we unfortunately have to take them out. But that's the sort of level of engagement and encouragement we want from the patients before we are ready to move forward with putting in the implant. So one option or one consideration specifically with the Boston Scientific platform is their research and development into the various ways to deliver the energy. So traditionally, we use something called tonic stimulation. So what that means is stimulation that matched up to the frequency that would affect the nerves. And so you would sort of feel a gentle tingle or buzzing, if you will, in the lower back legs, depending on where you precisely needed treatment. However, over the last several years, we've discovered that patients don't necessarily have to feel that in order to get pain relief. And the way I think of it, or the way I sort of explain it to patients, it's almost like a dog whistle. Dog whistles work really well for dogs, but we don't hear it. And why is that? Because they use different frequencies, just a way to deliver energy that doesn't tune up to our ears. And so these stimulators can do the same thing, that we can provide energy in such a way that you no longer feel it, but we can still stop the pain signals. And so the benefit of having some of these paresthesia-free, which means no tingling, systems or waveforms is that patients do find them more comfortable. We can allow you to drive with them. Traditionally, if you had a tingling system, we would have to tell you if you want to drive, you got to turn it off. But with the paresthesia-free systems, we are able to allow you to drive with those systems on. And then the other big component is for nighttime use. Sometimes Patients don't want to feel tingling at night while they're trying to go to sleep. And so by putting it in a paresthesia-free mode, you may be able to get significant pain relief without having to feel a tingling, which may keep you up at night. And there's been some research done by the Boston Scientific people that does show that depending on the type of pain that you're trying to treat, patients prefer the option to be able to bounce around and try different waveforms or different ways to deliver the energy. And that for pain that's down the right leg, maybe you need the paresthesia form, or the one that you feel the tingling. Maybe for the pain down the left leg, you actually need the one where you don't feel the tingling. And so by allowing you to play around with it and giving you some of these different programs, which are preset, you're able to have better control over the pain in that given moment. Again, this is just a good recall of one of the studies done by Boston Scientific showing, and this is a significant number of patients and followed for quite a while, showing that after 2 years of having a spinal cord stimulator, patients reported approximately a 6-point drop in their pain scores. And again, as I said previously, we don't only care about pain scores. While we use them to judge if we're helping, if we're making progress, we also want to see patients being able to do more, and their studies have also shown some of those benefits as well.
So at this point, I think it'll be a good time to address the questions. There's a lot coming through, so we can start reading them off. And I know Justin has to hop off at 6 o'clock, but Justin can contribute if there's any questions specifically on spinal cord stimulation that he can help answer. So going back to radiofrequency ablations, a patient asked if it could be done for knee pain.
Absolutely. So there are sensory nerves that are innervating the knee joint in particular. And so we're able to ablate 3 out of 4 of those sensory nerves to give patient near complete pain relief. These are typically for patients who failed cortisone therapy or gel injections. We move on to doing test trials first. And so we'll put numbing medication around those nerves first on 2 separate occasions to see if you do in fact get, good results from it, good pain relief from that. And if you do, then you would have the option to move forward with radiofrequency ablation, where we can go ahead and burn those nerves off for you. And like I said, these are purely sensory nerves. They don't affect motor function, so it's not going to affect your ability to use your legs at all. It just senses pain in the knee joint in particular, and so we're able to burn those off for that.
And I would just add in, that's actually one of the few options we have for patients who already had a knee replacement. So for instance, we can give injections of steroid or the gel shots into a knee that's not been replaced. You can't do that to a knee that's been replaced. It's all metal in there. It's not going to do anything. And if you're still having chronic knee pain after having a knee replacement, which is not completely uncommon, this is one of the few options that we can use to try and treat.
Another question, if you're on anticoagulants, can you go forward with the spinal cord stimulator?
So yes, but we always check with the cardiologist, right? We don't make those types of decisions by ourselves. It really comes down to why you're on the anticoagulant and if we can get a safe window to stop it. So prior to doing a trial or prior to doing any sort of implant, we would definitely have a conversation with the cardiologist, getting their blessing and permission to allow you to stop the blood thinner. Now, if they say, no, you cannot stop the blood thinner, unfortunately, we don't ignore what the cardiologist says, right? Everyone listens to the cardiologist. So we, unfortunately, at that point, wouldn't be able to do it. But there may be some other therapies we would be able to move forward.
Thanks, Dr. Johnny. A question regarding the Vertiflex procedure. Why can the Vertiflex procedure be beneficial if it's less invasive? And how does it make the pain more manageable?
Well, I think, when it comes to the spine, less is always more. The more aggressive the treatment in terms of surgery, the more opportunity for things to go wrong. And part of that is because the spine is such a delicate structure. All of these little bones and joints in our spine all have a role in allowing us to bend, twist, turn. And when you start to have surgery, you take away some of those pieces, and you take away some of that architecture. And that unfortunately puts additional stress on other areas that weren't meant to handle that stress. And so by being less invasive, not only is it a quicker recovery, less downtime, again, an outpatient procedure, but we don't create those other issues. As I said as well, the fact that it's less invasive and we are not going in there removing anything or cutting anything, it essentially leaves all your other options still on the table. And so if for some reason something else were to have occurred, or you had a new injury, the Vertiflex can be removed and other spine interventions can be done moving forward. And so I think that's one of the big highlights regarding both spinal cord stimulators as well as the Vertiflex. You're not burning bridges, right? Even with the spinal cord stimulator, if for some reason it's no longer helping, we can always remove it and then allow whatever else needs to be done to move forward. And in the same mindset, the Vertiflex does not preclude other interventions of the spine. And so I think that's one of the fundamental sort of differences between a lot of pain doctors and a lot of spine surgeons. Again, we prefer to do things that are less invasive, removable, reversible, whereas, like Justin said, once you get a fusion, you have a fusion. There's no going back from it. And so I think it's reasonable that you're able to keep your options open by trying these less invasive modes.
If anybody hasn't seen the poll pop up at the top of the screen, or it could be at the bottom in your Zoom page, you can see where it says polls, and you can vote on where it says polls. There's a patient that Dr. Johnny, I'm sure you'd recognize the name, but he contributed. He said, not a question, but before the stimulator, I could only walk 3,000 to 4,000 steps. Now I can do 10,000 to 14,000 steps. So you mentioned before, it's not only a decrease in pain that we look for, but also an increase in function. So
yeah, absolutely. I mean,
thanks for contributing.
Both. We want both.
Mm-hmm. All right, so many questions here. Another one was about hip pain. Can SCS help with hip pain?
So that gets a little complicated. The general answer is yes. We can use neuromodulation or we can use stimulators to try and target hip pain, but often there may be some other treatment options that we would try before we got to that point. One thing that I like to highlight to a lot of patients is, although we try and prevent patients from having major surgery, sometimes that is the right option. And so we would work together and have a conversation whether or not you would be a reasonable surgical candidate for potentially a hip replacement. If for other medical reasons or other various reasons you're not a good candidate for surgical intervention, that's where some of these other therapies kind of come in. But there is a standard pathway in which we treat some of these issues. And on there is joint replacement. But like I said, if you're not a great candidate, then there is a role for neuromodulation in treating both hip and knee issues.
There's also another question about arthritic pain and sacroiliac pain, and which route they should go with the therapies we discussed tonight.
I'm sorry, say that again?
There's a question about arthritic pain and sacroiliac pain, and which therapy would be best for them that we discussed tonight.
Got you. So, so in general, the best therapy is going to be radiofrequency ablation. The reason being is that there's nothing left behind, right? If we're able to accomplish our goal with a simple procedure that doesn't have any incisions and doesn't leave anything behind, that's the best option. And so after making sure that we are targeting the correct structures, making sure we know which are the arthritic joints, or we know in fact you do have SI joint dysfunction, a really good option is you can go in there and do the radiofrequency ablation to burn the nerves, looking for at a minimum 6 months of relief, but many patients do get closer to that year mark. Again, it's not a permanent treatment. Those nerves do regenerate, they do grow back, which can lead to the pain coming back. But at that point, it's simple enough to repeat the intervention. There are more invasive options, including using something like the sacroiliac joint, but we try and limit that to the ones that who have not benefited from some of these other options.
Thanks, Dr. Johnny. And before Justin hops off, I don't know if you're still there, but there was a question about the battery life. Just a question, how long the battery lasts. And I think you can help with that one, if you don't mind.
Sure. I'm on the really far end of the spectrum as far as kind of what you call a heavy user, just because I'm using all 16 of my available programs, and some of my programs really draw a lot of energy from that battery. So I wouldn't think my charging routine is really typical. I know I for a lot of patients, I know my grandmother is 93. She's implanted with the very same device I am. She's only running a few programs, and they're not drawing as much power. She's more average. She's charging once every 10 to 14 days for 3 hours. On my end, again, that farther end of the spectrum, I'm charging twice a week for about 2 hours. Whether it's twice a week for 2 hours or once every 14 days for 3, it's really, to me, it's not that bad of a trade-off when you consider what I get out of it, especially because it's really just, it's super simple. The charger looks like a hockey puck. Essentially, it's a little bit thinner in diameter. Put some double-sided tape on that. I just put it right on my skin above the charger, put my shirt on over it, and I usually just, I charge in the mornings when I'm answering email for the beginning of the day. And I just let it runs and it gets done. So it's really, I think it's patient specific. So you have my grandmother on one end and me on the other. So maybe some people fall everywhere, somewhere in between there.
Mm-hmm. Yeah, that's about on average. I think that's what most people see. It's customized to each patient and their specific pain pattern and how often they use it. But on average, it's about once a week. So thanks, Justin, for helping answer that. Dr. Johnny, there's a question about, actually, Dr. Choksi, you could help us with this one as well, about radiofrequency ablation and not helping it. If it doesn't help relieve the pain, is that a possibility? Are there more options after that?
I would say that that's really specific to the type of pain that we're talking about. There are, like Dr. Johnny discussed, the other options of Vertiflex and spinal cord stimulation to address those issues, because there's a lot going on in the back. There's muscles, joints, nerves, there's discs, and any one of those things and those things combined could be causing the pain. And so even if radiofrequency ablation doesn't cure or treat the pain, or if it's not the complete relief that a patient is looking for, then we certainly do have all these alternative options, and not just an SES or a Vertiflex, but even other injections that could potentially improve the pain relief or build on the pain relief that they got from the radiofrequency ablation. But again, that would kind of depend on the specific type of pain and sort of what else is going on.
I would also highlight that in many of our patients who have had previous spine surgery, if you have hardware in your back, radiofrequency ablation may not work as well if you have metal in the area. And it's just pure physics. You heat something up, metal loves heat, it draws the energy away from actually burning the nerve. And so there can be specific situations why it may not work for an individual as well. So it does come down to some of the sort of the nitty-gritty of exactly what's going on in that specific area.
You know, one also, before we do a radiofrequency ablation, we are doing the test blocks, right? So a patient goes through 2 diagnostic sets of blocks before we even move on to a radiofrequency ablation, because I think the remainder of that question was there a wrong nerve that was ablated or something? But you know, I think that in regards to that, we do the test blocks to ensure that we're burning off the correct nerves, that this does in fact give the patient the meaningful relief that they're looking for, and then we proceed with the radiofrequency ablation. So it's not that we just go straight to the ablation and kill the nerve, where there are steps for the process before we get there.
I think we addressed most of the questions in the chat feature, but I want to encourage patients to continue the conversation in the office. In the beginning of the PowerPoint, we showed the different office locations. I'm sure most of you are already familiar.